Anticoagulant therapy is used to prevent and treat blood clots. They lower the risk of serious conditions like stroke, heart attack, deep vein thrombosis, and pulmonary embolism. Clinicians commonly prescribe anticoagulants to patients with or at risk of thrombosis, including those with deep vein thrombosis, pulmonary embolism, atrial fibrillation, recent surgery, or a history of clots. FDA-approved classes of anticoagulants include parenteral therapies like unfractionated heparin, low molecular weight heparin, thrombin inhibitors, and oral therapies such as vitamin K antagonists, for example warfarin, direct oral anticoagulants. Heparin binds to antithrombin and enhances its capacity to inhibit thrombin, also known as factor IIa and factor Xa, thereby preventing the formation of fibrin clots. Key benefits of heparin therapy include a rapid onset and offset, no drug-drug interactions, no accumulation in patients with severe kidney disease, and complete reversibility with protamine sulfate. Limitations include a variable dose response, which necessitates frequent coagulation monitoring, risk of bleeding, heparin-induced thrombocytopenia, and the risk of osteoporosis with prolonged administration. Low molecular weight heparin is associated with a more predictable anticoagulant response than unfractionated heparin and does not require routine monitoring. It is preferred over unfractionated heparin because of its longer half-life, which enables once-daily injection and the lower risk of heparin-induced thrombocytopenia. Vitamin K antagonists, VKAs, such as warfarin, block an enzyme crucial for vitamin K activity, which is central for the synthesis of fully functional vitamin K-dependent clotting factors. These factors include prothrombin, factors 7, 9, and 10, as well as the natural anticoagulants, protein C and protein S. Warfarin is an effective and inexpensive anticoagulant. However, it has several limitations. These include variable dosing requirements across patients, multiple food and drug interactions, and a narrow therapeutic window, which necessitates frequent coagulation monitoring to ensure that the international normalized ratio remains in the therapeutic range. VKAs also have a slow onset of action, which necessitates overlap with a rapidly acting parenteral anticoagulant for several days in patients with or at high risk of thrombosis. Furthermore, VKAs have a slow offset of action, which complicates periprocedural management. Direct oral anticoagulants, or DOACs, are small molecules that bind reversibly to the catalytic site of factor Xa or thrombin and inhibit their activity. DOACs offer several advantages over warfarin, including a more predictable anticoagulant response that is not influenced by dietary vitamin K intake and fewer drug-drug interactions. This enables fixed dosing without the need for routine coagulation monitoring. DOACs are associated with lower rates of serious bleeding, especially intracranial bleeding, compared with VKAs. However, some DOACs are associated with a higher risk of gastrointestinal bleeding than VKAs. Key limitations of anticoagulants overall have the potential for serious bleeding, drug interactions, dosing challenges, and limitations specific to certain drug classes. Current research is investigating the potential of factor XI inhibitors to provide safer anticoagulant therapy.